The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everyone. My name is Jessica Burke, and I'm here with Andy Capehart, and we are with the Adult Protective Services Technical Assistance Resource Center, APS TARC, and we want to welcome you to our event, Navigating the Department of Veterans Affairs to Best Serve Those Who've Served, with our presenters who I will introduce here in a bit. Next slide, please. And again, we would like to thank you on behalf of APS TARC and the Veterans Health Administration and Veterans Benefits Administration. Before we get started, a quick disclaimer. This webinar is being hosted by the APS TARC, which is a project of the U.S. Administration for Community Living, Administration on Aging, Department of Health and Human Services, and is administered by the WRMA Incorporated. Contractors' findings, conclusions, and points of view do not necessarily represent the official policy of the federal government. Next slide, please. Now a bit about the APS TARC, if you're not familiar. The mission of the APS TARC is to enhance the effectiveness of APS programs by working with partners on use of data and analytics, applying research and evaluation to practice, encouraging the use of innovative practices and strategies, and providing individualized technical assistance to APS programs. We're here to help in any way that we can. Just reach out to us using the contact information that will be displayed at the end of the webinar. Next slide, please. Now on to some housekeeping. In the handout section of your webinar control panel, you will find today's slides. You may download these at any time. Please use your computer speakers to access audio for this webinar. Please make sure the speaker volume is adjusted to your desired volume. If you experience audio problems during the presentation, we recommend that you sign out of the webinar and re-enter to log back in. Next slide, please. This webinar is being recorded and will be posted to the TARC YouTube channel. We will notify all registrants via email when it is posted online and announce their availability more broadly through APS TARC outreach channels. Everyone attending today will receive an email approximately 24 hours with a link to download your certificate of attendance. Unfortunately, CEUs are not offered for this webinar. You may ask questions, share comments by typing them into the questions box at any time during the webinar or by raising your hand and we will unmute you. Next slide, please. Now I'd like to launch a quick attendee poll so that we can get a sense of who's in our audience today. I'll launch that poll now. Our question is, what profession do you identify most with? And this is a single choice answer. Adult Protective Services professional, other social services professional, medical professional, legal professional, or other. I'm going to leave this up here for a few seconds. So again, single choice answer, Adult Protective Services professional, other social services professional, medical professional, legal professional, or other. A few more seconds. All right, let's go ahead and close that poll. So we have Adult Protective Service Professional, almost 80%, other social service professionals, 17%, medical and legal professionals, each at 1%, and other at 3%. All right, thank you, Andy. We can go ahead and close that. Next slide, please. Now, it is my pleasure to introduce our speakers today. We have Andrea Berkheimer, LCSW, Facility-Based Project Assistant with the National Social Work Program. We also have Jaime Halaszynski, LCSW, Facility-Based Project Assistant, National Social Work Program. And then we have Abigail Werner, Policy Liaison, Compensation Service. So I'm going to go ahead and hand it over to our speakers for today.
Thank you so much. And you can go to the next slide. Hi, I'm Jaime. And before we start, I'm going to cut my camera briefly, but I did just want to come on camera just to give a couple acknowledgements. I wanted to thank Andy and Jessica for making all of this so smooth behind the scenes and helping us with a platform that we're not familiar with. I also wanted to thank Hillary Dalen and her team at ACL, and really a huge thank you to Jennifer Sperry from NAPSA. We've been having ongoing, regular, recurring meetings for the past probably year and a half that have really culminated in a number of trainings for APS to VA and from VA to APS, so that we can really better try to understand each other and maximize our efforts to care for our veterans. In addition, I wanted to thank all of you in the field. The work that you do is not easy, and it's so important. And at the VA, we could not be doing the work that we're doing without your support and collaboration. So I just really appreciate all of our APS workers so much. So thank you. And I also wanted to acknowledge all of our social workers on the call. This is Social Work Month, so happy Social Work Month to all of you, and thank you for your commitment to our profession. So I will cut my camera so I'm not distracting during the presentation, and we'll get started. But I just wanted to start by sharing the mission statement of the Department of Veterans Affairs. This is actually based off of a quote from Abraham Lincoln. Our mission is to care for those who have served in our military and their families, caregivers, and survivors. And the roots of the VA go back many, many years. And our mission today is as relevant today as it was a couple hundred years ago. And we can go to the next slide. There are actually 3 distinct arms or parts of the VA, and while we all have the same mission, we all have very different specialties that we do. And here today, we're going to be learning more about the Veterans Benefits Administration and the Veterans Health Administration arm. But the third arm of the VA is the National Cemetery Administration. Many people don't know that that is a part of Department of Veterans Affairs. And when we talk about NCA, as we call them, you may be familiar with our most famous national cemetery, that's Arlington National Cemetery, but there are national cemeteries throughout our nation, and veterans and their spouses are eligible to be buried in a national cemetery at no cost. So if this is a benefit that you're not familiar with, it's really an amazing, wonderful benefit that I would highly encourage. If you click on the link, it will tell you a little bit more about the NCA. So while there are 3 parts to VA, we all have special services, and we all do work in collaboration, but you may call one part of the VA and hear, oh, that's not, our area, and you get sent somewhere else. So really our goal today is to help you learn a little bit more about the different parts and learn how you can reach locally to the subject matter experts so that you're not getting bounced all over, so that you can quickly get to the right place. And on that note, I'm going to ask for the next slide and turn it over to Abigail.
All right, hello and good afternoon. I'm happy to be here today to share some more information about the benefits that are offered by the Veterans Benefits Administration. So I'm going to start with our service-connected disability compensation, which is a payment. It's a monthly tax-free payment that we award to veterans who got sick or injured while serving in the military, and to those veterans whose service made a pre-existing condition worse. So it's money. It's a financial payment. And we're able to award this disability compensation for a physical condition, whether it be a chronic illness or residuals of an injury, or for mental health conditions such as post-traumatic stress disorder that develop before, during, or after service. If we can go to the next slide, please. So when we award entitlement to compensation for our service-connected disability compensation, this means that the facts of the case establish that that particular disease or injury occurred coinciding with an event in the military service, or if it was a pre-existing condition that the condition was aggravated during that period of military service. And we do look at the unique facts in each case on a case-by-case basis. So in order for us to grant entitlement to compensation on a direct basis, we have 3 elements that must be met. There must be that evidence of that in-service event, injury, or disease. There must be evidence of a current disability, and then there must be that link or nexus between the two that helps support that that current disability had its onset or inception during military service. So to provide an example, if we, for example, get a claim for a right knee condition, if there's evidence that shows that there was, let's say, a training exercise injury to the right knee, and then we have current evidence that shows that there's arthritis in the right knee, typically when we process the claim, if we require that nexus, we'll request a medical examination to help obtain that nexus that indicates, yes, this current right knee arthritis is related to that in-service injury to the right knee. We're also able to grant entitlement to compensation on a secondary basis. So if we stick with that right knee example, let's say that you've been service connected for your right knee arthritis and it's increased in severity over time, where now it's impacted your gait and you've developed a left knee condition. Even if there's no evidence of a left knee condition in service, if objective evidence shows that that left knee condition is secondary or related to your service right knee condition, we're able to grant entitlement to compensation on that secondary basis. We are also able to award compensation based upon aggravation. So if we stick with the right knee example, let's say that there's evidence of a pre-existing right knee condition where the right knee was injured during like a high school sporting event. However, you re-injure that right knee during that same training exercise and now have that diagnosis of right knee arthritis. Even though there's evidence that shows that the right knee condition pre-existed service, if we have objective evidence that supports that that right knee condition was aggravated beyond its natural progression by the in-service event, we're still able to award entitlement to our service-connected compensation. Our last theory of entitlement is on a presumptive basis. And this is typically done in either statute or regulation, where VA will presume that a particular element of a claim is met, typically in situations where there's strong scientific evidence. So a common example of this granting on a presumptive basis is with veterans who served during the Vietnam War and were exposed to the herbicide Agent Orange. So what this means is if we receive a claim for a condition that we recognize, again, typically either in statute or regulation, as being related to that herbicide exposure, and we have evidence that the veteran served in that recognized location during the Vietnam era, we can grant on a presumptive basis. That third prong, that nexus between the two, is not required as the presumption establishes that needed link. So those are our 4 theories of entitlement to grant service connection. We have a direct, secondary, based upon aggravation, and then on a presumptive basis. So we can go to the next slide. So in order to pursue your claim for service-connected compensation, we do require an application that's substantially complete. I have a link here that you'll be able to access from the slide deck that will take you to our standardized forms. Depending on whether you're filing your original claim or if you are filing a claim that was previously denied, there's a particular form that you need to complete. So you can refer to our website for more information with that. And then the claim can be filed either online through our va.gov website. It could be mailed in on a paper form. It can be completed in person at our regional office or working through an accredited representative, such as a veteran service organization or through an attorney. And I always like to point out that a veteran can file multiple claims for multiple issues throughout their lifetime. There are no limitations on how many conditions may be claimed or on the number of claims that a veteran may submit. There's also no time frame restriction that mandates that a claim must be filed within a certain period after separation from service. So if there's a veteran who served over 50 years ago in the Vietnam War, and they know that they have this current condition that's associated with their time in service, I would still strongly encourage them to pursue that claim for compensation. We can go to the next slide. So when we award entitlement to compensation, we assign a disability percentage that's based upon the severity of that condition. The percentage is reflective of the impairment in earning capacity that that individual would experience resulting from that condition. And this is also in regulation. This is in 38 CFR Code of Federal Regulations Part 4, the Schedule of Rating of Disabilities, which is broken out by body system. And the rating schedule, it provides the guidelines for what disability percentage will be assigned for those conditions based upon severity, lab findings, residuals associated with that diagnosed condition, those sort of items. And then that assigned disability percentage will then determine how much payment or disability compensation that veteran will receive each month. If there are multiple service-connected conditions, we assign that single disability rating to each condition based upon the unique severity of each granted disability, and then we use a combined ratings table to determine that singular service-connected disability percentage. This is important to point out because we don't add up the separately diagnosed or the separately assigned service-connected disability percentages. It is a combined disability percentage. So we often get questions about why the combined percentage is separate from the simply just adding up the assigned disability percentages. So there's a link here to our combined rating table that helps explain how we determine that singular disability percentage a little bit and in a little bit more detail. And so what this means with long-term care, as I mentioned on the prior slide, as these conditions progress and increase in severity over time, it's important to file that new claim or that claim for an increase. As conditions worsen, if we stick with your right knee example, it might just, when you first filed your claim after separation from service, you might just have mild arthritis. But now if the arthritis has progressed to a severe arthritis, or if there's now laxity in that joint, or if you've developed those secondary conditions, you'll want to file a new claim for those secondary conditions or file an increase in the severity of the conditions that we've already granted service connection. Another important note is that we are able to grant entitlement to temporary total evaluations. So if you're hospitalized for a period of 21 days or more due to your service-connected condition, we're able to pay you at the 100% rate during that hospitalization period. And during a period of convalescence, if you require surgical intervention for your service-connected condition and then require a period of convalescence of 30 days or more, we're able to pay you at that 100% rate during that convalescence period. We can go to the next slide. So additional benefits that we offer, we have special monthly compensations. And so this is just an increased rate. It's just a little bit more money that we award when certain criteria is met. We have two of the more commonly special monthly compensation rates are housebound and aid in attendance. With the housebound rate, if you're service connected for a disability that's rated at 100% and then permanently housebound due to the severity of that service connected condition, we're able to award this special monthly compensation based upon you being housebound. There's also a statutory authority that allows us to grant housebound if you have a single service-connected disability rated at 100% and then separate disabilities that are combined at 60% or more. Our aid in attendance special monthly compensation is a little bit more money than the housebound rate, and we're able to assign this when you have that single service-connected disability rated at 100%, and then you're so helpless where you require the assistance with your activities of daily living, or if you're permanently bedridden or in a nursing home due to the severity of that service-connected condition. And then I have a link here to our special monthly compensation rates because there are more rates than just the two that I have listed on the slide here. Our special monthly compensation rates are reflective of unique disability patterns. So there's also levels of special monthly compensation if you have loss or loss of use of extremities, or with combined disabilities of deafness and hearing or visual impairment and hearing impairments, where we're able to award some additional funding in our special monthly compensation rates. So we can go to that next slide. Now, separate from our service-connected compensation, we also have a non-service-connected pension. and our pension is based upon your income and net worth. In order to be eligible for a non-service connected pension, the criteria is on the slide here, but the veteran must have an other than dishonorable discharge, have that limited income and net worth based upon a limit that's set by Congress, and then have qualifying service, which includes service during a wartime period. The last element is that you must be at least 65 years old or have a permanent and total disability or be in a patient in a nursing home or in receipt of that Social Security disability insurance. So this is separate from our service-connected compensation, and you're only eligible to receive one. So if you have eligibility for both our service-connected compensation and our non-service-connected pension, we'll award whichever one is higher. If we can go to the next slide. We also have benefits available to survivors. So similarly to the veteran non-service connected pension, we also have a survivor's non-service connected pension where the surviving spouse may be eligible to a pension if they've not remarried, and then have the same or a similar income and net worth requirement based upon a limitation set by Congress. The veteran still has to have that other than dishonorable discharge and then that qualifying service. And if that information is met, then the surviving spouse may be eligible for a survivor's pension. We also have a dependency and indemnity compensation, which is eligible to a surviving spouse, child, or parent if either a service member dies in the line of duty or if a veteran dies from a service-related injury or illness. And so that's, again, separate from the survivor's pension, but it's based upon that service-connected passing of a veteran. We can go to the next slide. This is just some general information about assisting claimants. If a veteran or a survivor wants to establish a claim agent or an attorney to assist them in the claims process, there's a form that needs to be completed. To appoint an individual as a claimant representative, you should complete the VA Form 21-22A. If you prefer to appoint like a service organization like the DAV or VFW, you'd use our VA Form 21-22, but the link here in the slide deck will take you to that appropriate information. Also on va.gov, if you would like information about getting help from an accredited representative, I have the link provided here. If you are interested in obtaining accreditation, that happens through our Office of General Counsel, and so there's a link to explore how to go about obtaining accreditation if that interests you. And then I also have a link in here if you just wanted to search to locate a representative. Another thing that I feel is always important to point out is that there are state departments of Veterans Affairs, and these are separate from the federal level of our Veterans Affairs office where we're at today. States also have their individual locations, which is helpful if you're in a remote location because state departments often have locations based upon county, and then states offer different benefits outside of what the Veterans Benefits Administration offers. To address things like free fishing licenses or free license plates or certain tax exemptions. So it's always worth being familiar with the benefits that the state offers in addition to what the federal VA offers. So we can go to the next slide. And then lastly, we just have some resources here. I like to refer individuals to our fact sheets for the Veterans Benefits Administration. We have fact sheets for the different benefits, and they're nice one-page documents that include information about the benefit we offer, who is eligible, and what form is needed to apply. Again, there's a link to that combined rating evaluation calculator, which is helpful when you're looking at rating decisions and trying to determine how we came up with that disability percentage. We recently passed the PACT Act, which has had a major impact on exposures to certain environmental hazards and presumptive conditions. It expanded benefits for our Gulf War veterans, our Vietnam era veterans, our radiation exposed veterans. So there's definitely a lot of helpful information there. And then lastly, I have a link to our special monthly compensation rates. because again, there's multiple different rates that you might be eligible for based upon unique disability patterns. So we can go to that next slide. And that concludes my portion of the presentation. Feel free to place questions in the chat and I'll answer anything that may come up. Thank you.
Thank you. And this is Andrea. I'm going to now start discussion about the VHA, or Veterans Health Administration. So we wanted to talk a little bit about how a veteran can enroll in VA healthcare. So there are several different options. The first is by phone. If they call the number listed here, they will get a staff member that will walk them through the application process. The second option would be online. If you would click on this link, that will be offered in the PowerPoint that you receive. It will take you to the site to apply online and walk you through that process. You could also download the application, fill it out by hand, and then mail it into the address listed here. You could also, any veteran can present to any of our VAs, and someone at that VA would be able to get them an application and try to get someone to assist them in that process and filling out the application. Next slide, please. So for the enrollment process, to apply and getting VHA healthcare gives you the opportunity, you can select which healthcare system is closest to you or be the most convenient for you. Once a veteran qualifies for enrollment, it is determined if they're going to have cost-free healthcare, and that's based on their service-connected condition or other qualifying factors. But it does not need to be a service connection. They look at a veteran's income and see if they may have copays or if they'd be able to get their healthcare free of cost. And those copays will vary, again, depending on service connection, depending on their income and assets. Certain veterans would be asked to fill out a financial assessment at the time of enrollment. And again, this will help determine if they will have copays for medical care, medications, if they'll get reimbursement for travel due to their health care needs. So they look at the previous year's gross household income of the veteran spouse and any dependents. Again, the healthcare, VHA Veterans Healthcare is for the veterans. It's not for veteran spouses or dependents. They cannot receive healthcare. Also, applications for this take about 35 minutes. It's not a huge burden, and they're usually processed within about a week. So once a veteran applies and turns in their application by any of those ways that I listed previously, they should hear back within about a week on if they're eligible and at what level they may be eligible for. So if they would get the free healthcare or if they may have copays. And just wanted to mention that the VHA can help connect veterans with mental health care, no matter their discharge status, their service history, or eligibility for VA health care. So I want to make that known, that if a veteran needs mental health services, to please link them to a VA so that we can help get them services. Next slide, please. So this is a map that breaks down our delivery of care by what we call VISNs, or Veterans Integrated Service Networks. There are 18 regional systems, as you can see here, and in each VISN, all of those healthcare systems work together to provide the necessary care for the veterans. They are made up of VA main medical centers and our CBOCs, or community-based outpatient clinics, in certain geographical locations. Next slide, please. So delivery of care, our healthcare systems are, again, big networks broken down into VISNs, and then in those VISNs, there's certain veterans medical centers. They provide a wide range of services. So each medical center is different based on how big they are, what location they are in. but the medical centers are going to vary in what services they provide. So if it's acute care or surgery, mental health, orthopedics, spinal cord injury, pharmacy, radiology. So again, be sure if you're looking at a VA, they are all listed on our website. You can go to that direct VA medical center and see exactly what services they offer, and if they have any satellite offices within that main VA medical center. The VA also has come a long way in offering VA Video Connect or telehealth services. What's just nice about this is that many of our veterans don't live close to a VA or one of our community-based outpatient clinics. So this enables them to get the care at that site that might be farther away, either at home or at a clinic that is closer to them. So in some of our larger facilities, they offer very specialized care. So a veteran could technically be at home, use their VA issued iPad or their cell phone or their own laptop with a camera and be able to do a video visit with one of the specialty programs or providers at that larger hospital that could be an hour or two away for them. Also, if they have an appointment at that larger clinic and they are close to their CBOC or their healthcare facility, maybe only 10 or 15 minutes to get to the clinic, they could go to the clinic, to our telehealth department, and they would help them. The telehealth technicians would help them then call in and do that video visit from the clinic to that larger hospital or that specialized program. Again, it's just a nice way for veterans to get all of the wonderful care that the VA offers from their home or close to their home. Next slide, please. In continuation of the delivery of care, again, a little bit more discussion on our community-based outpatient clinics. We like to call these our satellite offices. So they are usually spread out around or in the region of our main medical facility. Again, all of the CBOCs are going to be different in what services that they offer. So again, very, very helpful to find that CBOC or the medical center on our webpage and see what services are provided. Some are going to be, have our primary care, our PAC teams in there with also enhanced services like social work or mental health. Sometimes physical and occupational therapy will be offered at these CBOCs. We continue to grow our CBOCs and what services are in them, and we're especially trying to do this in our more rural locations so that our veterans have access to those care needs that they have. And as part of social workers are usually a part of many, many aspects of the VA. So you'll have social workers in these CBOCs that, again, provide certain care coordination or resources, case management services to help with the social drivers of health needs that the veterans have. We also have social workers that will be assisting with mental health services, either brief or just general requests, as well as mental health therapists, psychologists, and providers that can provide some more specific care to them and maybe medication needs. So when you get the PowerPoint, again, you can use this facility locator link to find the medical center closest to you or the veteran that you're helping. Next slide, please. We want to talk about our rural veterans. We have a huge rural veteran population. 2.7 million veterans who are enrolled in the VA live in a rural or highly rural area. So Congress passed in 2016 the establishment of the VHA Office of Rural Health. And this office has targeted research and programs and new models of care for these rural veterans to ensure that they are getting the same quality care that the veterans in the urban areas are also receiving. The goal of ORH is to strive to break down barriers separating rural veterans from quality care. And in doing this, they have promising practices, they have pilot programs, they offer every year in different service areas to, again, test out and ensure that we are getting those rural veterans the health care that they need and deserve. They also offer enterprise-wide initiatives, which again expands access to sites that serve rural veterans and those services that are offered at those sites. So it's really amazing work that they're doing, and the amount of rural veterans that we get to outreach to has just increased greatly in getting those services they need. Next slide, please. Next, I'd want to talk about our VA community care. So sometimes the VA closest to the veteran is still too far, or the VA might not offer in close proximity to where they live the services or care that they need. So VA offers community care. It's covered by the VA when the closest VA does not offer a needed service or is too far to travel. Authorization is needed for this care, and that can be done by the local VA medical center. So if a veteran's receiving health care and they have a service they need that they feel is too far away, that's a discussion they can have with their providers at the VA and their community care program to see if that's something they would be eligible for. Community care offers a wide range of medical, mental health, and other specialty services, including some alternative medicine like chiropractic care, acupuncture, sometimes massage therapy is needed. So again, a lot of different services offered if that VA doesn't offer it. Each VA works with a TPA or a third-party administrator in that region, and those TPAs have a care coordination network of providers. So again, all of this care has to funnel through the VA to community care. Veterans can't just go out in the community and say they're a veteran and they want this care. There has to be pre-authorizations done, again, from the VA to the community care provider. Next slide, please. So next we want to talk a little bit about VA healthcare and Medicare. Sometimes veterans feel that because they have healthcare provided through the VA that they don't need Medicare, and that is not necessarily the case. We always encourage veterans to enroll and apply for Medicare benefits because sometimes the VA doesn't offer everything, or maybe it's not a provider that they want that works with the VA. They want maybe a specific provider to provide that specialty care in the community. So having VA and Medicare provides the veterans still many options, so they can get care through the VA. But if the care through the VA that is offered, maybe they don't want to travel to the main site to get these services done, and maybe they're not quite far enough from the VA facility to get the community care, then having Medicare Part A and B will allow them to reach out to those services and have that covered under their Medicare care through community physicians, drugs that might not be formulary through the VA, and sometimes, again, prescription plans may be helpful or useful if there are copays that they have to pay through the VA. So again, we do encourage veterans to apply for Medicare or Medicaid too, if they're eligible for those services on top of VA health care. Enrollment in VA care is not considered credible coverage for Medicare Part B. Veterans with VA health care still need to pay a Medicare Part B premium for Medicare's outpatient coverage. It is considered credible to have VA health care coverage for Medicare Part D purposes, so for that prescription plan. Only veterans can enroll in VA healthcare, and again, as I mentioned before, VA healthcare is not for dependents or family members. The VA healthcare is just for the veterans that are enrolled in the system. Next slide, please. Most VAs offer one or the other, emergent or urgent care. Again, these are all specific to the VA. Emergency care would be that 24/7 all-around care, emergency department, just as you would assume in any community emergency department. And then the urgent care system is usually limited hours, maybe open 12 hours a day or 18 hours a day with a little bit more specific care needs. They might not have the broad range of services like surgical or emergency medicine available, but veterans could be seen in urgent care, and if need be, then transferred to an emergency department in the community if further care is needed. Again, emergency rooms vary on what services they offer through the VA. Some have social work services that can help, again, with needs like intimate partner violence, sexual assault, psychiatric emergencies, long-term care or skilled nursing placement, transportation resources, sometimes capacity evaluations or cognitive evaluations, and post-emergency department discharge follow-up. Next slide. Another part of VHA healthcare is inpatient care. And again, the size and what is offered in inpatient care is going to also vary on each VA, the size of the VA, and the complexity of the VA. So some VAs have just small acute care floors that just do minor admissions for maybe follow-up after being diagnosed with pneumonia or stroke or something like that. And others that are going to be more intense, that have ICUs for those intensive care, transplant, spinal cord injury. Some of those specialized units are going to be at those higher complexity VA facilities. And then again, as I said, sometimes we rely on the community hospital for services. So if a VA is smaller, has a smaller acute care, if a veteran presents and needs further care, we will refer them out to a community hospital. We have nurses and case managers that then follow that veteran in the community hospital and make sure their care needs are met. If we can bring them back to the VA, we try to do that. And if they're being discharged, again, making sure that social workers at the VA are making contact with them to help with that discharge planning to see if they need home health services or maybe a short-term inpatient rehab somewhere. So I'm exploring all of those discharge planning needs. We work with that in the inpatient care or in our community hospitals. Next slide. So speaking of nursing home care, the VA offers, several options if someone needs long-term care or short-term rehab. So within our VAs, we have what's called community living centers. They are VA skilled nursing facilities, similar to what you might find in the community nursing homes. They provide 24/7 skilled nursing, medical care. A lot of times they're used for short-term rehab. So after a knee replacement or maybe after a stroke, a veteran will come to our community living centers for some short-term rehab to get physical therapy, occupational therapy, speech therapy. They offer mental health services as well on these to, again, assist if someone has any mental health conditions, depression, PTSD, anxiety, or anything that might come along with whatever the reason they're admitted to the CLC. Again, if it's dealing with a new diagnosis or past mental health services. There are over 100 CLCs across the country, and again, those vary by VAs on how big they are and what services they offer. Some are very small, and some are also very large. One thing that is great about the community living centers is their ability to help with hospice or palliative care patients and that end of life care. I think it's very specialized in our community living centers, specialized for our veterans. Just a great way to honor their life there at the CLC. We can also refer veterans to our community nursing homes. So these are non-VA nursing homes, but we have contracts with. If a veteran has a service connection, 70% or more, they may be eligible to receive care at one of these community nursing homes free of charge to the VA. Again, there's eligibility criteria for that. They must be enrolled in the VA. But these are some options. These would be our community nursing homes that we have contracts with. So if our CLCs do not have any beds, or maybe they're not close to where that veteran lives, we can pursue community nursing homes. There's also state veterans home that we work with through the VA. VA is federal, but these homes are state funded, and the VA works very closely with them to help get veterans into these facilities that need it. Now, this is usually, again, more long-term care needs, but some veterans home also have personal care homes or domiciliaries associated with them that other age-related veterans can use. And again, they do provide full-time care. And these are also eligible for veterans' spouses. So if a veteran served and their spouse needs placement, spouses can also pursue placement at a state veterans home. So that is all I have for my part of the presentation. Next slide, please. I am now going to pass it to Jaime to discuss more about outpatient care in the VHA. Thank you.
Thank you, Andrea. And I wanted to reference our primary care setting. In the VA, we call our primary care teams PACT teams. And this is a little bit confusing because this is entirely separate from the PACT Act. So you may have heard a lot in the media about the PACT Act and opening up eligibility to veterans to come to the VA because of a toxic exposure. I highly, highly encourage, if you know anyone who has said, oh, I tried to apply to the VA in the past for healthcare and they turned me down, they said I wasn't eligible, encourage them to apply again because really Congress sets the rules and the guidelines for healthcare eligibility. And just because you applied in the past and weren't eligible, you might be eligible now. So that's really an important fact that I want to get across. But our VA outpatient teams are called PACT teams as well. Again, different from the PACT Act. The important piece to remember with our PACT teams is that every single veteran in VA who has healthcare has access to a social worker in the primary care setting. It is going to be key for you to learn who your social work point of contact is because they can help to navigate this large system that we have. And we can move to the next slide, please. Just very briefly, these are some of the guiding principles of social work practice, but I think we have a lot of social workers on the call, and for the sake of time, I'm going to skip to the next slide. Social workers are experts in navigating the social drivers of health, and one of the things that we know is that, and I'm probably preaching to the choir a little bit here, but health conditions and SDOH really matter a great deal. I like to say if somebody has diabetes, but they're not living in a safe environment, or they don't have access to go to the grocery store for healthy food, they're not going to care about managing their blood sugar because they're not going to be able to. So I think all of you on the front lines really encounter those social drivers of health on a daily basis, and your VA social worker can also help you with those things. Next slide. Just very quickly, this is a map. The darker orange represents the older concentration of veterans living in states. So our veteran population is aging and their needs are more complex. Our older population is really no longer our World War II veterans because there's so few of them. There are so few Korean era veterans. Our population that's aging now is our Vietnam era veterans whose care is much more complex. Next slide. Veterans are also at a higher prevalence of risk factors than the general population for elder abuse or elder mistreatment. The reason that they're at a higher risk is because many of them have multiple comorbid medical conditions, and also many of them were exposed to trauma, whether it was through the military or a non-military related trauma. But our veterans are at higher risk for financial problems, for cognitive impairment, for substance use disorders, behavioral health needs. Really, we're seeing an epidemic of loneliness, as our Surgeon General has talked about, and really functional impairment, that you just can't do the things that you were able to do in the past. Next slide, please. So again, making contact with your VA social worker is key. Social workers are not just experts in VA resources, but we also couldn't do our job without our community partners. So we collaborate really across the continuum of care. We're able to help our veterans to coordinate their appointments. If a veteran does not have any transport to the VA, we can help to arrange transportation, which I think is an amazing benefit because I can't imagine my own doctor's office doing the same thing. So we really will try to jump through hoops and do what we can to get someone in the door. We're doing a lot of evaluations for cognitive problems, for safety, for elder mistreatment and neglect. Move on to the next slide, please. We're also in the primary care setting reaching out proactively to our veterans who have high risk factors. We really do know the veterans on our panel and really trying to do more preventative care than just the crisis management or putting out the fire. Now, that's not to say that crises don't walk through the door, but by virtue of having that long-standing patient-aligned care team, that primary care team, we're really able to see and follow up with our veterans over time. And we're really doing some targeted training to our primary care social workers to help them understand that if there's a suspicion of abuse or neglect, we do report because we're mandated reporters, but we have more resources in the VA, and a handoff to APS is not like a handoff and we're done. But if anything, it should be a sign that we in VA need to increase our interventions and our outreach to veterans. We don't, in the primary care setting, have the ability to go into the home as you all do, so that partnership with you is so important, but we are able to follow up longitudinally and long term, which is certainly a benefit. And again, we want to not just hand off to APS, but continue to be involved. Next slide, please. Also, we do a lot with advanced care planning, really trying to prevent someone from getting to the point that they're not able to make decisions and they have no named decision maker. So that's a large part of what we do. And really, we're engaging our veterans on what their goals are and what matters most to them. Next slide. I also wanted to just reference very briefly, we have a national policy on abuse and neglect reporting. And oftentimes national policies will supersede state ones. However, this national policy says you must follow your state reporting guidelines. So if you are a mandated reporter, you must report because we're required to do so. And you also must make a referral to a VA social worker for ongoing follow-up. Because again, it's not just a handoff to APS, we want to be following up. So we have national policy that mandates this, and we follow very closely with that. Next slide. In addition, just very briefly, we do have some medical legal partnerships. And through these partnerships, we're able to bring in attorneys to some VAs to talk about elder law, issues related to child custody, landlord-tenant disputes. So we have 31 medical legal partnerships at VA facilities nationwide. We're also really just trying to educate that there can be on-site legal clinics. So it's quite broad what we can do at VAs, but we like to say if you've been to one VA, you've been to one VA. We have 171 medical clinics, medical centers across the nation, as Andrea referenced. So just because there are all these services in one VA, there may be very different services in another VA. Next slide, please. Also, just very briefly, guardianship. Our hands are tied in VA, kind of similar to how yours may be with the guardianship process. It is against federal law for VA to take over as guardians. So we are kind of faced with some of the same difficulties with our veterans in inpatient units are really not at the correct level of care because they don't have a guardian. So again, we feel that a guardian is a last resort, but under those last resort circumstances, it can certainly take some time because federal law prohibits VA from taking over or acting as a guardian. Next slide. Okay, I wanted to kind of wrap up so that we had enough time for questions. If there is nothing else that you take away from our time today, just really want to emphasize, please learn who your contacts are locally for the VA and collaborate with social work. So there's a link on the slide that is for your local VA medical center. And if you find the VA that's closest to you, the numbers will be listed on the link there. You just need to call and ask for the head of social work, and they can be your point person because we know that this is you know, a large system to navigate and you don't have to do it alone. You want to be able to get to the right person. So if you know your local social work chief or executive, they can help to get you to who you need so that we can provide the best care for our veterans. And with that, I'd like to conclude. I know we have just maybe 5 or 6 minutes left. We're not able to see the chat, so Andy and Jessica, I will send it back to you to see if there's any questions for us. Thank you.
Thank you, Jaime, and thank you to all of you for what a great presentation. I really appreciate the really 360 overview of the VA, the different departments, how to access them, how to partner with them, the warm handoff. As doing APS investigations myself out in the field for 12 years, I found this extremely informative, and I can just see the intention behind this in ensuring that all participants on the webinar today have the guidance and tools that they need to help their clients successfully navigate through the VA system. So friendly reminder for our participants, the handouts, I've gotten a lot of questions on that. You can download those. They are here within the webinar. You can download this presentation, and also this presentation will be uploaded to the APS TARC, and you will get information on that. So as Jaime said, we do have time for questions. So one question I'm going to start with, I got a few of these. Team, how long does it take for a veteran's application to be processed?
For healthcare, are you referencing?
It was general, let's say for healthcare, for benefits, and even, let's say healthcare and then for compensation, disability compensation.
For healthcare, Andrea, and I can take that one, it's pretty quick. I mean, it's not unusual for us to get an application in, for our registration staff to take a look at it, and for them sometimes within a day or so to be reaching out to schedule an appointment. Andrea, is there anything else you'd like to say?
Yeah, as I said, yeah, in the presentation, it's usually, yeah, it can be as quick as a day or two, depending on where they present and how they, you know, enroll. But usually within a week, we're really trying to get those applications turned around quickly so that they know if they're eligible and for what care.
And Abigail, do you want to talk more about some of the benefits end?
Sure. So for our disability compensation claims, our goal is to have those claims processed within 125 days. Some claims are processed quicker, some take a little longer. It depends on a range of factors, whether that be obtaining your service treatment records, private medical records, getting that exam scheduled, if the exam has to be rescheduled, those sort of items. But our goal is to process claims within 125 days.
All right, thank you so much. Another question, can the VA apply for guardianship although they're not able to be appointed as the guardian?
We cannot. There is federal law that prohibits that. We did submit a proposal in the legislative proposal, and it's still, we're waiting for it to kind of filter through Congress for VA to be a little more involved, but there are restrictions. So we can't step in as guardians. Often we're collaborating with community agencies. If our first option is obviously to try to find a next of kin or a family member, but if there's truly no one, then we're collaborating with our community partners.
All right, thank you. Next, I kind of have more of a specific question. Somebody had said that they are struggling with the client getting community care because when we speak to the VA, they tell the veteran that they won't be part of the VA and will lose their benefits. So anything about the messaging there?
Without knowing more of the situation, I really can't comment. I would say that is definitely a situation you want to talk with the local social work expert, because I just really can't comment. Andrea, I don't know.
Yeah, I was going to say the same thing. It's very specific, and so depending on how much care they're getting in the community, depends on how much care they can get at the VA. So every situation is different. So yes, I would recommend them reaching out to maybe their PAC social worker to help navigate this, or at least help get them to the person that can answer that question.
All right. Looks like we have time for one more question. So do disability benefits and for dependents if the service-connected veteran passes away? So this is not pension, but disability.
So if a veteran passes away, or if a service member passes away during their period of service, or the veteran passes away due to service-connected conditions, that's our dependency and indemnity compensation. And that's a set rate. It's not income-based, but it's based upon that service member or veteran passing away either in service or due to that service-connected condition. And that's eligible to surviving spouses, children and or parent. And I would just refer you to our website for more information on eligibility for that.
All right, thank you so much. Next slide, please. Oh, you got ahead of me, Andy. Perfect. Here's all our information. Please contact us and follow us. On behalf of APS TARC, I want to thank our presenters for such a great informative webinar. A friendly reminder, this will be uploaded up to the APS TARC website. We'll get that information out to you as soon as possible. And a very friendly reminder, you will be sent a survey link. Please, please, please take that survey. We do value your feedback. And we want to thank you all for attending this webinar today and enjoy the rest of your day. Thank you.
Thank you.